63-year-old male coming in with past medical history of diabetes type 2, hyperlipidemia, hypertension, and CKD stage 3 due to shortness of breath for the past 10 days while walking. He says rest improves it. It worsens walking short distances or climbing the stairs. No precipitating factors. He's experienced shortness of breath before, but never this long. It's worsened since the onset, and he can no longer catch his breath. He says he hasn't been able to leave the house the past 2 days, and it is constant. Positive for weight gain of the past 2 weeks, 5 to 7 pounds, lower extremity swelling, orthopnea, paroxysmal nocturnal dyspnea twice this week, negative for chest pain, palpitations, cough, speed and production, lower extremity pain, negative personal history of cancer, COPD, asthma, stroke, DVT, PE, and MI, but his father passed away from an MI and his mother from a stroke. No pertinent social history. He does have a penicillin allergy. He gets a rash. He currently takes lisinopril, metoprolol succinate, atorvastatin, metformin, and aspirin. He's currently hypertensive at 148/88. His O2 sat is 91 on room air. Heart rate is a little tachycardic at 102, respiratory rate at 22, and his temperature is good. He's completely oriented, mildly tachypnic, but no acute respiratory distress, no JVD, mild neck vein distension, a regular rhythm of the heart, but tachycardic, as said, no abnormal heart sounds, auscultation of bibasilar crackles heard on the lung, negative for wheezes and rhonchi. He has mild tachypnea. Abdomen is mildly distended, no fluid wave or hepatic enlargement. Dorsalis pedis and posterior tibialis pulses both intact, but he does have 3+ pitting edema of the bilateral lower legs mid-calf, negative erythema or warmth. His BNP is significantly elevated, his glucose is elevated, his BUN is significantly elevated, creatinine significantly elevated, and his sodium is low. His troponins are negative, and his white blood cells are within normal limits. Chest x-ray shows cardiomegaly with pulmonary vascular congestion and mild bibasilar interstitial edema. His EKG shows ST elevation in leads AVR and AVL, indicating a lateral STEMI. Because of this STEMI, we need to admit him. He needs an echocardiogram, cerebral troponins, and continuous EKG monitor. We need to refer to cardiology and pulmonary rehabilitation. He needs morphine, oxygen, nitroglycerin, aspirin, metoprolol succinate, lisinopril, atorvastatin, and enoxaparin. He likely had an MI 10 days ago, so he's no longer a candidate for reperfusion therapy, so we're going to focus on the pulmonary rehab and educate the patient on likelihood of previous MI and continue to check up on patient throughout hospital status. He likely has heart failure from the MI, so he needs an echocardiogram, repeat CBC, and continue to monitor electrolytes. And we can begin sacubitril and valsartan in 36 hours and empagliflozin for his heart failure.